come to order. It's a sad reality that roughly 17 veterans on average are losing their lives to suicide every single day. One death alone from suicide is one too many. But it is a sobering reality, and the loss of just one veteran has a profound ripple effect on their fellow veterans, their families, and their communities. Like most of my colleagues across this dais, one of my top priorities on this committee is to decrease the number of veteran suicides. As we have examined this year through multiple hearings, there are many factors that come into play when a veteran loses hope. And as we have also examined, there should be no limits on what we can examine as potential solutions. As a 24-year Army veteran, I've seen unique challenges that many of my fellow service members and veterans face, both in service and as they adjust to living back in their communities. It's imperative that we continue to work on solutions such as the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant Program to give veterans and their family members the support that they so desperately need and deserve, and that support is available wherever they live. Over 60% of veterans who died by suicide in 2021 were not seen in VHA in 2020 or 2021. And over 50% had received neither VHA nor VBA services. In order to reach all veterans, we must continue to expand our work in the community. Fox grants assist veterans and their families by providing veteran-based outreach, veteran suicide prevention services, connections to the VA, and additional community resources with the focus on reducing the number of veteran suicides. Throughout this process, veterans and their families are provided assistance on how to connect with VA clinical or non-clinical help if eligible. According to the VA's just-released annual suicide prevention report, through June 2023, grantee organizations reached more than 10,000 veterans and their families in need. Coordinated assessments by these organizations identified approximately 130 imminent risk veterans and resulted in 800 non-emergency referrals and approximately 1,800 social service referrals to address drivers of risk, such as homelessness, unemployment, income supports, and legal services. These are not just numbers, these are veterans' lives. The committee recently sent out a request for information to grantees of the program and received an overwhelming amount of positive feedback. As we look to the future of this grant program, I'm eager to better understand what can be done to address any process challenges and expand on any potential opportunities. I would like to thank the VA for their commitment in providing aggressive technical assistance to grantees through various forums and working groups. The program office responsible for implementing this pilot embraced this mission, and we look forward to continued dialogue with them as we move forward. Thank you all for being here, and I look forward to hearing the perspectives from our witnesses on this important program, especially now as we continue to struggle with the stubborn suicide rate among veterans. With that, I yield to Ranking Member Brownlee for her opening statement.
Thank you, Chairwoman Miller-Meeks. Today's hearing will focus on one of the most complex topics and biggest challenges our subcommittee faces, and that is suicide amongst our nation's veterans. At the outset, if anyone listening today is struggling with thoughts of suicide, or if you know a veteran or service member who is in crisis, please reach out to the Veteran Crisis Line. Simply dial 988 and press 1. You can also send a text message to 838255 or go to veteranscrisisline.net for an online chat. You will reach trained responders who are ready to help. Last month, the Department of Veteran Affairs released its 2023 National Veteran Suicide Prevention Annual Report, which provided data on suicide mortality among veterans and non-veteran U.S. adults over 2 decades, from 2001 through 2021. Sadly, the overall number of suicides among veterans rose between 2020 and 2021. Women veterans were among the most heavily impacted subpopulations in 2021, as there was a 24.1% increase in the age-adjusted suicide rate for women veterans compared to 6.3% among male veterans. Any life lost to suicide is a tragedy, and this committee continues to examine all possible suicide prevention strategies and ways to increase veterans' access to quality mental health care. Over the past several years, Congress has passed more than 40 veterans' mental health bills through standalone and omnibus legislation. These include the Commander John Scott Hannon Veteran Mental Health Care Improvement Act, the Veterans Compact Act, and the STRONG Act. These bills contained dozens of provisions that aim to increase veterans' access to mental health care, strengthen VA's suicide prevention programs, bolster VA's research and mental health workforce training, establish pilots to examine complementary and integrative approaches, and improve the transition from active duty to veteran status. One such pilot program was the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant Program. It was created in 2020 under the Hannon Act. It took some time for VA to stand up this program and publish the necessary regulations. In September of 2022, VA awarded the first round of grants to 80 organizations in 43 states, the District of Columbia, and American Samoa. The second round of grants was awarded about 3 months ago, with 77 of the original grantees receiving grants again, along with 3 new grantees. These are now grantees in 43 states, Washington, D.C., Guam, and American Samoa. The goal of the Fox Grant Program is not to expand access to direct clinical care. Rather, it is to partner with organizations that provide services to address some of the upstream factors that can contribute to veterans' suicide risk. Such factors include housing instability, employment instability, legal trouble, lack of social support and engagement, and unstable interpersonal relationships. The primary population Congress aimed to reach through the Fox Grant Program is the approximately 60% of veterans dying by suicide each year who have had no recent engagement with VA healthcare. I hope to hear more today about how grantees are putting Fox Grant funds to use, and hopefully we will hear some success stories about veterans whose lives may have been saved by this program. I will acknowledge that it will be some time before the potential benefits of this program will show up in VA's annual suicide prevention report, as each report published reflects data from 2 years earlier. However, before we consider reauthorizing the Fox Grant Program, the subcommittee needs to know more about the impact of these funds that the funds have had and see some clear measures of success. In accordance with the Hannon Act, within 18 months of awarding the first Fox grants, that is by March 19, 2024, VA is required to report to the House and Senate Veterans Affairs Committees about the effectiveness of the Fox Grant Program. Perhaps today's hearing can provide a preview of VA's findings. I look forward to a robust discussion. Madam Chairwoman, before I yield back, I wanted to take a moment to recognize the service of the Republican staff director of the Health Subcommittee, Ms. Christine Hill, who I understand will be retiring soon. Back in early 2020, about 6 weeks before the pandemic, Christine and I had an opportunity to travel with several other committee staff to South Dakota and North Dakota, where we visited the Cheyenne River Sioux Indian Reservation and Standing Rock Sioux Indian Reservation. We had a lot of fun and learned a lot. We learned a lot that the trip about veterans' barriers to health care, housing, and transportation. And we also got to know each other a little better as we traversed several hundred miles through Indian country. Counting her 20 years in the Air Force after graduating from the academy, some time working in the Senate and at the VA, and most recently her 10 years with the committee, Christine has spent over 36 of her career in federal service. We are sorry to lose her wealth of experience and institutional knowledge, but Christine, your retirement is very well deserved, and I wish you all the very best in your third chapter. Thank you for your service to your fellow veterans and to our nation. And with that, Chairwoman Miller-Meeks, I yield back.
Thank you, Ranking Member Brownlee. I'm going to say ditto and save any comments for later. I'd like to introduce our witnesses on our panel today. Joining us today, Dr. Erica Scavella, Assistant Undersecretary for Health and Clinical Services, Department of Veterans Affairs, Todd Burnett, Senior Consultant for Operations, Suicide Prevention, Department of Veterans Affairs, PhD in Psychology, Misty Myers, Director of Community Integration, American Warriors Partnership, Ken Falke, Chairman, Founder, Boulder Crest Foundation, and Joyce King, Project Director, Staff Sergeant Fox, Veteran Suicide Prevention Program, Sheppard Pratt. Dr. Scavello, you are now recognized for 5 minutes to deliver your opening statement on the VA.
Thank you. Good morning, Chairwoman Miller-Meeks, Ranking Member Brownlee, and distinguished members of the subcommittee. Thank you for the opportunity today to discuss the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant Program. Accompanying me today is Dr. Todd Burnett, our Senior Consultant for Operations within the Suicide Prevention Program. The grant program honors veteran Parker Gordon Fox, who served in the Army and joined the Army in 2014. Unfortunately, he died by suicide in July of 2020. The grant program authorized by Section 201 of the Hannon Act represents an important step in leveraging community networks and expertise in veteran suicide prevention efforts beyond what we can do within VA. The grant program complements VA's 10-year national strategy for preventing veteran suicide. It supports and aligns with the priority goals in the White House's strategy for reducing military and veteran suicide. Given the multiple factors that may lead to suicide death, preventing suicide requires a comprehensive public health approach. What this means in practical terms is that VA must harness the full breadth of the federal government in close partnership with states, territories, tribes, and local governments, as well as collaboration with industry, academia, communities, community-based organizations, families, and individuals to prevent veteran suicide. I'm proud to report that the grant program is providing resources toward community-based prevention efforts to meet the needs of veterans, their families, and other eligible individuals through outreach, suicide prevention services, and connection to VA and community resources. The impact of this program has been meaningful. I would like to share 2 stories that illustrate just how this program has affected those who've sacrificed for our nation. The first is a young woman who was pregnant. She was a veteran, and she fled from a domestic violence situation and engaged a grantee for services. She was enrolled in prenatal care and other healthcare supports at VA. She is quoted as saying, "I could not have survived without your help." Another example is a Marine Corps veteran who presented to a grantee with suicidal thoughts, seeking help for combat-related trauma. After getting linked to help, he confided that he had been engaged in steps towards ending his own life. And had he not contacted the grantee, that would have happened. He says that the services saved his life. VA has collected and received many more examples like these. These engagements within grantee communities are critical interventions needed across the nation to prevent veteran suicide. As of October 31st, 2023, grantees have completed approximately 20,000 outreach contacts and engaged over 3,500 participants. The grant program facilitates engagement within clinical mental health care, but it is unique in that most services that are provided are actually not clinical. As the nation continues to recognize, as we as physicians recognize, as we as healthcare community recognize, research evidence confirms that the social determinants of health are drivers of suicide risk. The grant program takes a bold step to acknowledge and meet the need for suicide prevention interventions outside of clinical care. The grant program is proudly in its 2nd year. Beyond the formal evaluation process, we are implementing solutions for lessons learned in real time to improve the grantee and participant experience. Just last week, VA convened its 4th 2-day technical assistance meeting in Orlando, Florida, with over 150 grantee representatives present. Attendees received tailored technical assistance as well as the opportunity to connect with grantee peers. In conclusion, we are grateful for the enactment of the Hannon Act and other laws that have helped to fuel advancement in veteran suicide prevention. The grant program is one tool that VA has rolled out in its public health approach to veteran suicide prevention. We need everyone at the table. We need everyone working in the same direction. This requires both moving away from the belief that suicide prevention rests solely on the shoulders of our mental health providers and moves us further towards engaging within and outside of clinical healthcare organizations and delivery systems to decrease both the individual and societal risks of suicide. Suicide is preventable, and each of us has a role to play. This is our mission, and we're so thankful that you are with us along this journey. This concludes my testimony. My colleague and I are prepared to answer your questions.
Thank you, Dr. Scavella. Ms. Myers, you are now recognized for 5 minutes to deliver your opening statement.
Chairwoman Miller-Meeks, Ranking Member Brownlee, members of the subcommittee, thank you so much for your invitation to testify today regarding the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant. America's Warrior Partnership is a proud recipient of the Fox Grant, and we utilize a unique upstream community integration model to accomplish the goals set forth by this grant, to work with communities to prevent suicide. I'd like to share a story. On November 13th, a post-9/11 Army veteran called our national network with an active plan to end his own life. He had moved from New York to Florida after a divorce, and he was facing bankruptcy. He was in crisis. He was not happy with his care he received from the VA in New York. He was tired of taking all the pills. He said they were prescribed for both his PTSD and bipolar disorders. He had an appointment the following morning for a medical evaluation with the Fort Myers VA. This gentleman, we wanted to get a referral for mental health the next morning. He was in agreement with that. I reached out to the local suicide prevention coordinator there in Fort Myers and was unable to get a call back. I left a message that we had an actively suicidal veteran that needed care, and that call has still not been returned. However, we were able to connect with the 988 crisis line and get that veteran the support that he needs. We're still working with him and walking with him for as long as he will let us. AWP network staff worked hard to connect that veteran with the services that he needs, and we're so thankful for the 988 crisis line being available to us. While he states he loved his girlfriend too much to take his own life, he certainly needed the support we were able to offer. Our goal is to improve the quality of life for veterans and to end veteran suicide by empowering local communities to serve them proactively and holistically before a crisis. In September of 2022, outreach began with the Fox Grant, and by March 2023, AWP began enrolling Fox participants. Since that time, AWP has completed intakes and suicide risk assessments for 1,057 warriors via the Columbia Suicide Severity Rating Scale, as required by the VA. 185 of those men and women indicated some level of suicide risk. This means over 17% of that 1,057 had some level of suicidal ideation. Once AWP knows a veteran or service member is experiencing some level of suicidality, we must find them local and national resources. In an acute suicidal crisis, as I said, that results in a call to the crisis line and a referral to other local counseling centers. However, there is no expedited care for Fox participants. There is no special number or special intervention to serve those people immediately. This is one of the major shortcomings of the Fox program. There is no program. It is a transaction. It needs to be relational, not a VA-sponsored phone call for assessments with no plan or infrastructure on the back end connecting to services. The Fox Grant program needs to have follow-up available for veterans in need, and making sure that that infrastructure is in place and not having veterans disclosing these thoughts with no services available to them. Following the intake and suicide risk assessment, we create a holistic service plan. If the veteran is willing, we conduct additional assessments for the participant. There are 9 different assessments and questionnaires required for the participant to be enrolled. Several assessments have ended with an additional call to the 988 crisis line. Once the participant has received referrals and has been connected to support, we are required to then administer the baseline assessments. We have only had 6 of our 180 Fox participants complete that entire process. And both staff and veterans describe the assessments as both repetitive and exhausting. To eliminate redundancy, the psychosocial, ISIL-12, and GSE assessments could be removed or combined and shortened with other assessments. We already know that depression, isolation, and financial hardships are risks for suicide. How does continually assessing known stressors better our prevention model? In addition, the amount of data gathered is significant. AWP has submitted thousands of forms to account for outreach efforts and Fox Grant requirements, necessitating the hiring of additional administrative staff to handle the load. We are in year 2 of the grant's life cycle, and the data collection tool was made available to AWP just yesterday. We have not tested that system to see how it will work from here on. Finally, there is no clear measure of success for the Fox program. Is it a number or an outcome? Does success come with potential increase in funding? And are those organizations unable to meet their metrics held to account, removed, or reduced? There is no bigger picture on how all of this data will impact VA policy to improve the lives of our veterans. Thank you, subcommittee members, for the opportunity to testify today.
Thank you, Ms. Myers. Mr. Falke, you are now recognized for 5 minutes to deliver your opening statement.
Good morning. I want to begin by thanking this committee for its essential and hugely impactful work on behalf of our nation's veterans and their families. Chairwoman Miller-Meeks and Ranking Member Brownlee, thank you for your leadership and the opportunity to speak to the subcommittee regarding the Staff Sergeant Fox Suicide Prevention Grant. I also want to thank Representatives Bergman and Houlihan, who as veterans themselves took the lead on the creation of this legislation with the assistance of so many others. I served in the U.S. Navy for 21 years as a Special Operations Bomb Disposal Specialist. Since my retirement in 2002, I have become an advocate for my brothers and sisters. A major driver of my work is the nearly unspeakable truth that since 9/11, we have lost more members of the bomb disposal community to suicide than we did on the battlefield. This truth is nearly unspeakable because the work that my community does on the battlefield is considered to be the world's most dangerous job. Sadly, this epidemic is not limited to the bomb disposal community. In response to these challenges, my wife Julia and I founded two nonprofit organizations, the EOD Warrior Foundation in 2004 and Boulder Crest Foundation in 2010. Since then, our organizations have served over 100,000 program participants. Boulder Crest, Virginia is the nation's first privately funded wellness center dedicated to combat veterans and their families. Our vision was to create a place and programs where combat veterans could transform their struggles into strength and growth. Broadly speaking, our nation's mental health system is not focused on accomplishing this goal. The mental health system is nearly exclusively focused on one thing when it comes to clients and patients, and that is managing and mitigating symptoms associated with times of struggle, often through a combination of medication and talk therapy. This approach is not working for far too many people, something made evident by the highly distressing statistics around veterans' mental health and suicide. In 1995, Dr. Richard Tedeschi coined a term, post-traumatic growth, to describe how people reported growth in areas of their lives in the aftermath of traumatic events. In 2014, we partnered with Dr. Tedeschi in the development of and delivery of our Warrior Path program. Warrior Path is the first training program ever designed to enable our nation's combat veterans to transform deep struggle into profound strength and lifelong post-traumatic growth. It's a 90-day program, non-pharmacological, peer-delivered, and delivered at 9 permanent locations in the United States and through 2 mobile training teams for a total of 11 Warrior Path programs per month. In short, we have developed a program that achieved the vision set forth to ensure that veterans could be as productive at home as they were on the battlefield and live extraordinary lives filled with passion, purpose, growth, connection, and service. In 2022, Boulder Crest was one of the 81 organizations awarded a grant from Staff Sergeant Fox Suicide Prevention Program. Our grant's for $725,000, which only covers the delivery of 12 Warrior Paths and the administration and reporting functions required by the grant. Boulder Crest and our partners have delivered over 465 Warrior Path programs to over 3,000 students. Across the more than 10 clinically validated measurement tools that we use to measure the impact of Warrior Path, to include those required by the Fox Grant program, participants report experience symptom reduction and improved growth more than any other program. The establishment of the Fox Grant program is a realization of something I have long believed was necessary, and that is a true public-private partnership based on the goals of ensuring at-risk veterans do not fall through the cracks, and the identification of innovative and effective programs that are effectively and sustainably addressing the suicide epidemic amongst veterans. In light of the ongoing conversations with the VA and the data from the VA-funded Warrior Path participants, we propose 5 key recommendations to enhance the program. The first one is to remove the funding caps. Today, only 24 of the 132 annually delivered Warrior Path programs are funded under this grant. Revise the eligibility criteria. We need to rethink the use of the Columbia Suicide Scale, primarily because we often see the PHQ-9, which is a depression scale, scores out of sync with the Columbia scale. And as you know, depression is the leading cause of suicide. We need to broaden the veteran eligibility. My personal belief is that all veterans should be eligible for this program, regardless of the score on a test that's only taken for one day. Number 4, we need to include traumatic brain injury centers. We need to expand the eligibility to include leading privately funded clinical TBI centers. TBI is a significant risk for veteran suicide and needs to be treated clinically. And finally, we believe that we need to expand the collaborative partnership between the VA. We believe that the more people that understand post-traumatic growth, the better chance they will learn to thrive in the aftermath of trauma and help others do so. I believe these steps are vital to our united mission to support our veterans' well-being and reduce the veteran suicide epidemic. My team and I are committed to being active, contributing partners in this mission, and I am deeply thankful for the opportunity to address you today and look forward to any questions.
Thank you, Mr. Falke. Ms. King, you are now recognized for 5 minutes to deliver your opening statement.
I would like to begin by thanking the committee for this transformational work on behalf of our nation's veterans and their families. I applaud Chairwoman Miller-Meeks and Ranking Chair Member Brownlee for their leadership, and I greatly appreciate the opportunity to speak to the subcommittee regarding the Staff Sergeant Fox Suicide Prevention Grant Program. My name is Joyce King. I serve as the director of the Staff Sergeant Fox Suicide Prevention Grant Program at Sheppard Pratt. I'm a board-certified mental health therapist and substance abuse counselor, as well as a 16-year Air Force veteran with more than 25 years of mental health, substance use, and social services experience. Sheppard Pratt is the nation's largest private nonprofit provider of mental health, substance use, developmental disability, special education, and social services in the country. We provide specialized services for veterans, including supportive services for veteran families, SSVF, Homeless Veteran Reintegration Program, HVRP, and clinically intensive grant per diem transitional housing. Many of these programs are funded by the U.S. Department of Veterans Affairs. Collectively, Sheppard Pratt's Veteran Services assist approximately 1,200 homeless veterans every year in urban, rural, and suburban communities across Maryland and in select counties in West Virginia. Many of our staff are veterans, including some staffs who were previous clients. The dedication and commitment of our team drives our impact. We have helped over 5,235 homeless veteran and veterans' families to obtain permanent housing. Our HVRP program helps homeless veterans to obtain employment with an average wage of just under $20 an hour. In 2022, the VA released a Staff Sergeant Fox Grant Notice of Funding Opportunity. Its deep focus on community connection, well-being, and suicide prevention responded to a clear gap in the community-based services for veterans. Accordingly, we jumped at the opportunity to better serve our veteran community. The application process was well-organized and transparent, with significant flexibility and approach provided by the VA. The staff of the VA deserve credit for designing and implementing a disciplined, efficient application process. Sheppard Pratt was honored to be awarded the Staff Sergeant Fox Grant in September of 2022. Our implementation strategy combines a comprehensive and holistic strategy set selected based on the best available evidence for the greatest potential to prevent suicide among veterans across Maryland. We leverage current programming and relationships with veterans that are high risk, yet disengaged with the VA in mental health care. Peer support is a critical component of our Staff Sergeant Fox implementation strategy. Through this new funding, we have trained veterans with lived experiences related to suicide and mental health. Our peer support specialists work directly with the veterans and their families to promote connectedness, provide holistic case management, and reduce risk factors associated with suicide. In addition, case managers help veterans with a range of health, housing, employment, and other needs. As the Staff Sergeant Fox Grant Program was only recently launched, our data is preliminary but suggestive. During enrollment, 95% of our veteran clients indicate a need for mental health services. 75% require connection or reconnection to the VA services and supports. 65% report benefits challenges. 60% request peer support and connection, and another 60% report health, housing, employment, and other challenges best addressed through case management. The need, therefore, is clear. The impact of the Staff Sergeant Fox grant program is best demonstrated through stories. I would like to share a story of one of the participants. I'll call her Alice. Alice's story illustrates the power of the Staff Sergeant Fox grant program, as well as the way in which community-based veteran services, including SSVF and HVRP, combine to prevent suicide and promote well-being more generally. Alice is a 48-year-old single veteran, single female Navy veteran with a history of post-traumatic stress disorder and traumatic brain injury. Alice recently experienced 2 traumatic events. In 2022, she was laid off. To make ends meet, she moved in with her sister. In 2023, her sister passed away unexpectedly. With the loss of both her job and her sister, she fell behind on her rent. She had to make a choice between paying her rent or buying food. In September 2023, she called Sheppard Pratt. Our Staff Sergeant Fox program team collaborated with SSVF to help Alice find more affordable housing option. To help Alice gain employment, our Staff Sergeant Fox and HVRP teams worked together to provide Alice with both a computer and technological training. And Alice dedicated herself to her job search. Within a month of her calling Sheppard Pratt, she had a new job in the IT field. While Alice was working to obtain a new job in housing, she was simultaneously grieving the loss of her sister. The Staff Sergeant Fox peer support specialists were instrumental in modeling healthy and effective coping strategies. Today, Alice is working, living stably in safe housing and in a healthy home. She shared the impact of Staff Sergeant Fox in her exit survey. Quote, "I can say for sure that the program and all of the team went above and beyond my expectation. I honestly never felt like I was alone during the process. In fact, the opposite almost. I literally felt like a team was assigned to me for different stages and aspects. I couldn't be more grateful," end quote. Alice's comments about the Staff Sergeant Fox program are echoed by other participants. John Woodard, a former Marine, similarly was struggling with PTSD, a job loss, and eviction when he connected with the Staff Sergeant Fox program. John tells his story better than I can. He said, quote, "Sheppard's Veteran Services got me and my family out of a situation that I was in before where I was not appreciated and was not being supported for my mental illness. Now I'm in a better location with my family with a peaceful mind instead of a crime-infested area where I could hardly sleep because of fear and hypervigilance. I would like to thank the Veteran Services programs for coming to my rescue. I've been using this time to heal and to get help with my PTSD."
Thank you, Mrs. King. We appreciate your testimony. We'll now proceed to questioning. I will defer my questions to the end. I now recognize Ranking Member Brownlee for any questions she may have.
Thank you, Madam Chair. Dr. Scavelli, I wanted to ask you with regards to metrics and what the VA uses as metrics to measure the success of these grants.
So thank you for the question, Ms. Brownlee. So as you heard from our fellow witnesses, there are a number of metrics that we do use to assess how our veterans are doing. There are some that are required, some that are taking place later on in the process. I'm going to ask Dr. Burnett to add the details on which ones are required at the beginning and which ones we conduct during the course of the care.
Thank you. There are 3 primary areas that we use to evaluate the success of this program, the first being reduction in suicide risk. The second, of course, being perceptions of well-being. Hanen 201 requires that we make assessments not only of immediate suicide risk, but also overall well-being to push the interventions as upstream as possible to prevent the escalation of people who are feeling suicidal. And third is the connection to veterans who are most at risk and currently unconnected to services.
So certainly the first one is important. All 3 are important. In my opinion, the 2 and 3 are a little bit harder to actually assess and put into to a metric. But what about, one of the other objectives of this grant program is helping veterans who are not enrolled to enroll in VA healthcare? Is that something that you measure? Also, one of the other objectives of the program was to reach out to the approximately 60% of veterans who've had no connection to the VA at all. Are those metrics that you will be collecting?
Yes, and we will provide information on both of those things to you in the interim report that's coming to you in the spring.
Okay. And can you speak to, in the VA's testimony, they talked about the number of organizations and the amount of money that has been awarded so far. If you break that down on a per veteran basis, it's pretty expensive. So can you, do you have any way to explain why the cost per veteran of this grant program seems to be so high?
Thank you for that question. It's not unexpected in the first year of this pilot program as these grantees are establishing their services. The first half of last year, they were really getting their programs up. They weren't required to begin seeing veterans until January. And so what you've seen is that trend increase pretty dramatically. So as of December, for example, we had approximately 100 veterans that were participating in the program, and by October 31st, we had 3,500. You had just around 120 outreach events in December, and that reached 20,000 by the end of the year. We expect that trajectory to continue into the second year here, but that does help give some context to why that cost was so disproportionate at the beginning here as they ramp services.
Thank you. Mr. Falke, I think in your testimony, I think it was you who mentioned that it doesn't cover all the costs. Am I quoting you correctly?
I think in my written testimony, I talked about the cost, but you know, the Warrior Path program, it's a cohort-based program of 8 veterans per program, and we deliver 11 of those programs a month. Only 2 of them are funded.
Two of them?
2 of them are funded by the grant. The rest of it's all funded philanthropically through private donations. So I'd love to see it expand and cover all of them, you know, assuming that Warrior Path is in fact identified by the VA as one of the critical programs to solve this problem.
Thank you for that. And I want to thank all the grantees who are here for the work that you do for our nation's veterans. We appreciate it very, very much. I wanted to also ask, as I mentioned in my opening statement, that the age-adjusted suicide rate among women veterans has increased significantly in 2021, and if any of the grantees can speak to that, and wondering if any of your organizations are specifically targeting programming towards women veterans.
We run, our Warrior Path programs are run as male and female cohorts. Initially, we were doing, if you take Boulder Crest, Virginia, we were running 12 programs a year. 2 of those were for women veterans, 10 for male, which is a little disproportionate to the amount of women who serve versus men. I think it's 90-10, and we were doing 80-20. In the last 3 years, we've had to increase the number of female programs because of the demand. And that's kind of how we respond as a small nonprofit, is based on the demand. So we'll transform one of the male cohorts into a female cohort. With the network we've created around the United States, 11 programs now delivering it, we're at about 27% of the veterans who go through our program as female.
I'd like to, I know my time is up, but I would love to follow up with you and talk in greater detail about some of the differences between men, women, et cetera. It seems there's a lot of good information in there. Thank you. I yield back.
Thank you, Ranking Member Brownlee. The chair now recognizes Representative Bergman for 5 minutes.
Thank you, Madam Chair. You know, when you turn on the evening news, they start with good evening, and then for the next 27 minutes, they tell you why it's not. And then for the last 3 minutes, they give you good feeling stories to come back and take the abuse the next night. So we're going to flip that on its backside. A couple of years back, Chairman Boston and I had the honor of visiting Boulder Crest, Virginia, and we were grateful, Mr. Falke, for your selfless efforts to serve so many in the Mill Vet community 22 years naval service, followed by the creation of 2 nonprofits that have served more than 100,000 folks, is an incredible achievement and one you should be proud of. What we saw at Boulder Crest was quite simply visionary. In your testimony, you mentioned that traditional mental health is focused on one thing only, quote, managing and mitigating the symptoms associated with times of struggle, often through a combination of medication and talk therapy, end quote. If I were to appoint you as the new mental health czar at VA, do you think you could spend that $16.5 billion in a more focused manner? I know you stated a lot of it in your comments, but if there's a couple of things you'd like to share with us here, because we're still in the good news phase of my 5 minutes.
Do you have any harder questions, sir? You know, I served in the Navy 21 years. I was in the government contracting business for 10. So I've been through this contracting process. I will say, hands down, this VA process has probably been the smoothest thing I've ever seen. It's really, and I'm not just saying that because I'm here, it's really been a great process. How the grant was rolled out, how the outreach programs work, the partnerships in Orlando. But you're right. I think, you know, I tell people all the time, I've raised $200 million in the last 20 years for veteran causes, nearly $200 million. I've been shot at, I've disarmed bombs in the middle of the night, I've been jumped out of airplanes, been diving in deep, dark waters, and there's nothing harder than raising money. And one of my frustrations with the VA, and I've been fairly outspoken, 3 of the last 4 secretaries have been to Boulder Crest, Virginia. Bob McDonald is on our honorary board. One of the problems that I've seen, and we were instrumental, I think, in part of the lobbying efforts around this grant, is that there's not real good community partnerships. And there doesn't seem to be a sense of urgency that I saw in the Pentagon.
I'm going to cut you right there.
Yes, sir.
Because you just made the key phrase that in my 7 years here on Veterans Affairs, the idea of when, by the way, thank you. But we've had countless testimonies here where we have asked the VA, how will you get a sense of urgency behind your efforts? So, you know, Dr. Scavello, there's growing frustration on both sides of the aisle because the news doesn't get better, and we are still, even though we may have a dip from year to year, the overall rise is still unacceptable. But put bleakly, over $150 billion has been spent since 9/11 on this issue. And when you look at the ratio of suicide in the community, it has only gone up, never down. In fact, in comparison to the general population, it only continues to get worse, not better, despite significant resources spent. You know, in the 116th Congress, I, along with some of my colleagues, worked very hard because we had grown frustrated with the VA's lack of progress over time on this. Could you outline the VA's specific objectives to reduce veteran suicide over the next 5 years going forward, ideally broken down by year? What achievable metrics will you use to measure success? And you've only got 20 seconds to do that, so if you'd like to take it for the record, I would really like to see a timeline, however you want to put it, because no results is just that, no results. And we need to put the money where we're going to get the results for our veterans. And with that, I yield back. Madam Chairwoman, may I have 30 seconds to say that to our Christine, you know, in naval terms, you've served honorably, and fair winds and following seas we'll see in the future.
So recognized. So is that it? It's better to ask for forgiveness than ask for permission. And Dr. Scavella, if you will please follow up with the question from Representative Bergman and send in that response, which would have taken much longer than 20 seconds. I too would like to see that data. So if you could submit that in writing to the subcommittee, that would be greatly appreciated. The chair now recognizes Representative DeLuzio for 5 minutes.
Thank you, Madam Chair, and good morning, everyone, and thank you for your commitment to helping solve a crisis in our veterans community. Dr. Burnett, I'll start with you to follow up a bit on what Ranking Member Brownlee was asking about the report that this committee and our counterparts in the Senate will see. What's most useful from where I sit is understanding, are grantees effective, and are they effective relative to VA? And on the cost question, I heard you answer part of that, is this a cost-effective, are we seeing cost-effective performance, again, relative to VA? So my first question on reducing suicide risk factors, do you plan to report to us that success or failure relative to how VA is doing here?
Preliminary indications are very good. So 73% of the people who have started and completed this program have seen an improvement in well-being or reporting an improvement in well-being, which is a good first-year start for this.
So let me dig in a bit there then. Do you have that same data and have that same metric for those who are seeing care within the VA, and will you be reporting that data about grantees and or VA to us in the report?
So keep in mind, many of these, so 80%
Some aren't eligible.
Well, so you have 7,000 support recommendations or referrals that were submitted. Almost half of those are for non-emergency mental health care, and 80% of those are coming to VA for services. When you look at emergency services, so when they are screened, as we talked about the screeners earlier, more than 300 are identified at the time of that screening for as being at high immediate risk, and 78% of those are going to the VA or vet centers for care. About 22% are going to the community or other organizations, and we can provide you that information.
Yeah. You get the thrust of what I'm interested in seeing there. And similarly, I heard the explanation on some of the high costs per veteran. It will still be useful from where I sit to see how the financial performance is relative to what a similar cost per care metric is within VA.
Of course, understood. We evaluate that as a part of our business operations process and reviewing all grantees.
Good. This could be either Dr. Burnett or Dr. Scavella. The grant recipient in my district and region, Veterans Leadership Program, they run the PA Serves Care Coordination Network across the Commonwealth. We say Commonwealth in Pennsylvania. They have a good relationship with the Pittsburgh VA. I've seen that coordination. I've seen the referrals that pass through both directions. I'd like to know if VA is assessing and whether we have a way to assess whether that's happening elsewhere, and if you have tools in place or you need different ones to encourage that kind of coordination with other or for other grant recipients.
Yeah, so thank you for that question. So when our veterans are engaging with any of the grantees, they are required to try to get them in for services with us. So that is one way we are doing that structurally as part of the program, part of the procedures. As far as data related to how many have actually done that and how many are engaged, we can get that information, and that's something that we are very interested in because we are trying to tackle that 60% group of veterans who are not enrolled, engaged with us.
Yeah, I think it's another way for us to assess whether this is successful or not is to see that level of coordination reported to us. So I'd encourage you to include it as well. Madam Chair, I yield back.
Thank you, Representative DeLuzio. The chair now recognizes Representative Van Orden for 5 minutes.
Thank you, Madam Chair. Just to go over a couple numbers here, $16.5 billion requested last year, $150 billion since 9/11 applied to this problem set, and we have an increase in veteran suicide. So as an enlisted guy who doesn't have the this highfalutin degrees and whatnot, to me that's just abject failure. So how much of this money have you guys given to faith-based programs? I'm talking to you, ma'am.
I'm going to defer to my colleague. I don't know the answer to that question.
Very well. Dr. Burnett?
15% of our current grantees are faith-based organizations.
Okay, I would like a list of those, please. Are you familiar with the program called Mighty Oaks Foundation?
Yes, sir.
Okay, do you know what their success rate is?
Not off the top of my head.
They've treated approximately 5,000 veterans, 2 of which have committed suicide. That smokes any of your programs you got going on. And so I have some very basic questions here. So you guys are failing. I'm not going to sugarcoat anything. You're failing my brothers and sisters. The Master Chief isn't. Ms. King, you're not. And ma'am, sorry, I took my glasses off. I can't read your name right now. Yeah, you know who I'm talking to. Anyway, you guys you're doing God's work. And I know you guys are trying, but you're just not pulling it off at all. So if I understand this program correctly, you guys are failing completely, and we are now giving you money to give to people that are succeeding. I mean, is that right? I mean, that's what this is, right? We're cutting you checks through the chairwoman to give you money to give to people whose programs are succeeding. Did I miss something? I mean, that's what we're doing, right? So the very basic question is, why does your office exist? You're like an incredibly expensive middleman. So what can we do differently? My colleague, Mr. Luttrell, has got some language in for psychedelic treatments. I don't particularly agree with it completely. However, it works. Faith-based programs work. So we've got to do something different. You have to do something fundamentally different because your treatment modalities are failing. And with Senior Chief Mike Day, I've had 21 of my Navy SEAL friends commit suicide to date. And I'll guarantee you there's going to be more. So this is a statement. You guys need to do something different. And if that means we hack half your staff and take those salaries and benefits and give them to those 3 people, then that's what we need to do. Because it ain't about me, it's not about you, it's not about your job, it's not about your career, it's not about an agency. It's about saving our brothers and sisters' lives. So, Ms. Meyer, I want to thank you. Master Chief, thank you very much. Ms. King, thank you for your efforts, I appreciate it. And I understand you're trying, but it ain't working. And from our previous line of work, that means you got to go. With that, I yield back.
Thank you, Representative Van Orden. The chair now recognizes Representative Landsman for 5 minutes.
Thank you, Madam Chair. Thank you all for being here and working on what is one of the most significant crises that we face as a country. And getting at the question of what's working, what's not working, and where we go from here, several members and I, in a bipartisan fashion, kicked off last week a What Works caucus to help us as lawmakers, the administration, do a better job at ensuring legislation, programming is evidence-based, that we're using data to not just see what's working, but getting better, continuous improvement. And so this is for everyone across the board. What are we measuring now? What are the inputs, outputs that you think are most important? What should we be measuring? And, what's the best way forward for us to track this as a committee? Because, getting this right is so hugely important. So I'll just turn it over and maybe go right to left, left to right, in any event. What are the most important measures in your mind? Are we tracking them? How do we make sure that this committee has visibility into that and can be as helpful as possible?
Yeah, thank you for that question. So one of the main things we are tracking is going to be looking at the number of the suicides. Not only has it risen within the Department of Veterans Affairs and our patients, but in the community as well. We want to keep track of all those instances that have been successfully avoided. So we will be documenting and reviewing that data, and we will continue to do that. And also, we know that this is a complicated problem. So one of the concerns is that how do we make sure that we're looking at things that are not purely clinical? So this program has been impactful and visionary in the fact that it's not only looking at clinical services, but also looking at community services. faith-based organizations that are helping us, as well as other innovations. So that's really where we're pushing the needle into territory that's new. And so that's what I would offer. I'll turn it over to Dr. Burnett.
Thank you for that question. Two things in particular. Are we reaching the right people? And are we making a difference for them? So your question earlier was about how do we know we're reaching women veterans, or American Indian, Alaska Native veterans, or veterans 35 to 54. Those are three populations that you saw significant increases in 2021 report. So 23% of the participants in this program are women. 40% are veterans or individuals who are 35 to 54, and about 10% are American Indian, Alaska Native, Asian American, Pacific Islander, Native Hawaiian veterans. And more than that, and what the information you'll see is what is the risk at the time that they're coming into this program. And so about 70% of each of those groups are coming into these programs as identified as being at high risk or moderate risk for suicide. And then what is the impact when they leave this program? Did we make a difference now? I shared with you about 73% of those so far. Now, we're just in our first year, so we don't have all the information we're going to have, but that's the information we need to be presenting to you and making decisions based on what works and how we know it works.
I've got a minute left, so maybe we could circle back, or you could submit to the committee what measures that you all are using. Maybe you already have done that, but I just wanted to say, as we think about this, and this may end up being something we work on as a committee, but in Cincinnati, where I'm from, we have one of the best children's hospitals in the country, and they will tell you that they got to be in the top 2 or 3 because they focus entirely on this idea of getting better, being the best at getting better, and using data and continuous improvement to provide the greatest possible care. And so with something so complicated as this, something so important as this, reducing veteran suicide, I would love to see us do more, especially with this grant program, to ensure that we are making, that every dollar is going to the highest impact program possible. Thank you, and I yield back.
Thank you, Representative Brownlee. The chair now recognizes Representative Luttrell for 5 minutes.
Thank you, Madam Chairman. Veteran suicides, we've been parked on 6,000 plus veterans for about 20 years now. That's a fair assessment, correct? Anybody say yes, because that's the number. You should be screaming that one, which is 6,000 way too many. Dr. Scavella, you previously just said we are moving into kind of a more innovative approach on how to address these things. Now, when people read these numbers, they see the number.
Yes, sir.
I'm a researcher by trade. Before I showed up to this place, you guys are researchers too. We know the underlying factors. We do. And for 20 years, we've known the underlying factors. Is that a fair assessment?
Yes.
So why is it 20 years later we're just now moving to an innovative approach? All right? I say this on just about every single committee I sit in front of the VA, is I can't imagine the rucksack that you're carrying every single day. You two, sitting right there. It's unforgivable. It is. You should be the 2 people in this room that go to bed every night and get up every morning sick to your stomach because we have 6,000 plus veterans dying every year. It's not a fun job. I understand that. You have these 3 organizations that are pushing the envelope as best they can. If they didn't exist, imagine what those numbers would be. To my colleague to my right here, and he stated those faith-based, and the organizations, they grow. I think there's more veteran service organizations in America than any other organizations possible. 40,000 or 400,000, it's crazy numbers. When the VA grants these nonprofits or for-profits money, does the information that they gather annually come back to the VA, and does the VA share that with other organizations so they can tailor their processes to be similar or to grow? Either one of you two.
Sure, I'll start and then I'll pass it on to Dr. Burnett. So one of the important factors with this is that we're not being prescriptive to the T for every single program. We're allowing the programs to innovate and to set forth programs that they think will impact the actual community that they're
Does the
taking
VA
care of.
have a portal or an enclave of every single one of the facilities that exists so and what's the turnaround time from a call to the VA hotline to Mr. Falk's organization?
Yeah, so if someone's calling the hotline, they're getting an answer on that call. That's not being called back, that's an actual answer. With regards to the reporting, our teams are getting regular engagement and information back from the organizations that are participating in the program on a monthly basis. And then we're also there for any technical questions and things like that that may arise. Is there anything I've missed, Dr. Burnett?
No, I think you captured it, and I think what you're getting at is the foundation of a public health approach to suicide prevention, which is a big part of the
The VA should be leading the charge on that. You shouldn't be able to walk across the United States and you should be able to ask somebody who's leading the charge on suicides in America, and the first words out of the mouth should be the VA. That doesn't happen. Congress, I dare say this committee, subcommittee, and committee would most likely give you as much rope as you needed to go out and take this from 6,000 to 0. I think what we're waiting on is for you individuals to come to us and say, we hit 6,000 this year, I'm going to promise that will not be the number next year. I haven't heard that yet all year.
So I didn't hear a question there, but I do want to comment on.
That was more of a statement, but
Yeah.
you can respond if you'd like.
I just want to emphasize that this is our top clinical priority, our top priority period, and that we are committed to this work.
How long have you been in this position?
I've been in this position since 2020,
Okay.
2021, excuse me, sorry. But I've been with the VA for my entire career as a physician. I've been committed to taking care of veterans from the time I became a physician. So this is very important to us. We have gotten to this place because we've looked at the data and seen that despite all of our efforts, we do have a large component, 60%, who are not engaged with VA at all. So we're trying to find ways to get to them to make sure that we are taking care of them as well.
That's a perfect point, and I'll close with this statement, but thank you. I don't think we're catching it early enough. By the time those broken bodies and brains show up to these organizations, the round is downrange. I'd like to hear after what the VA working by, with, and through DOD is doing to catch the members as they leave our services so we can get in front of it. Statistically, there's got to be numbers out there that say these problem sets, these characteristics, these mannerisms will inevitably lead to, we're AI-based. There's got to be a way we can figure this out. I'd like to, for a follow-up, if we could get those numbers and know exactly how the VA is working with the DOD to decrease these numbers. I yield back, Madam Chair.
Thank you, Representative Luttrell. To correct for the record, when I thanked Mrs. Brownlee, I meant to thank Representative Landsman, so thank you, Representative Landsman. And I now recognize Dr. Murphy for 5 minutes.
Thank you, Madam Chairman. Apologize, this is one of those ping pong days, as we all know so very well. Thank you all for coming. This is an important, obviously, purpose, really, of our VA subcommittee. I don't know if there's anyone necessarily greater, because these lives lost are tragedies that are absolutely, in my opinion, preventable. I'm very fortunate. About 1/10 of my district, actually 1 in 10 constituents, is a veteran. Camp Lejeune, Cherry Point, several other places are well within my district. So it is one of the largest constituencies in the fabric, really, of Eastern North Carolina. I cherish our veterans, and whenever I'm ever driving anywhere, if I'm stopping off for gas or something, I always give somebody a challenge coin, because it's just a small thing that we can do to always help our veterans. That said, I feel like we're failing these individuals, and I'm going to pick up a little bit where Mr. Luttrell stepped. If we're not starting this from day one being the day before they leave the service, we're failing our veterans. And I have the Veterans Bridge Home in my district and the Buncombe Community Christian Ministry, and these agencies do a great job, but we need to really, in my opinion, start this from day one. The fact that we can't touch these folks is a big deal. Hyperbaric oxygen is a big deal for me. I think it's changed lives. We've had hearings on psychedelic medicine. which is innovative and interesting. There are a lot of research studies going now on mitochondrial injury, on how that can produce suicide. I just wonder if I could ask, and we theorize a little bit, as we're encroaching now literally a wheel formation in medicine and in technology with artificial intelligence, where does the VA see that as being able to help our veterans? Because so many times, I've been a physician now for 35 years, I'm able to build upon my experience to help take care of patients. But with AI, we're going to be able to use the knowledge base essentially instantaneously of millions, if not billions or trillions of experiences. And how are we going to be able to use that to help prevent veteran suicide?
Yeah, thank you for that question. So as I'm sure you're aware of, we are in the middle of a tech sprint where we are asking companies who have innovations that can help us to take care of our veterans to give those proposals to us so that we can put things into place to make changes in how we're delivering care. So we see artificial intelligence as well as the entire spectrum of those technologies as potentially instrumental and impactful in what we're doing for our veterans.
How does that process look like? What is the timeline?
I'm not sure when the tech sprints close, when we get all the proposals back, but they're ongoing currently.
Do you expect to have to come back and ask for further funding, or is there funding within the VA to do that?
I can't answer that question. I'd have to talk to the finance team about that.
Okay.
I'm not sure.
This is a critical issue, and despite the number being taken down statistically and really just by administrative change being taken down from the number being taken from 22 to 17, it's still the same number. It's still the same number, and I think it's a ruse on the American people that we all of a sudden dropped 5 suicide deaths per day. That's not really true. I applaud you all for what you're doing. This is critical. This is the life-changing element that not only touches one life, but it touches so many other lives. We can't get caught in the bureaucratic nonsense, either of outside the VA or within the VA. It's one life at a time. Thank you. With that, Mr. Chairman, I will yield back.
Thank you, Dr. Murphy. The chair now recognizes Representative Kiggins for 5 minutes.
Thank you, Madam Chair, and thank you all for all your work you're doing here. I don't need to restate some of the statistics, and we all say that one veteran suicide is too many. I know that many of you mentioned just some of the assessments that I think, Ms. Meyer, you mentioned that only 6 of 180 of the assessments were complete. And just reading the list of requirements of all the different scales and assessments you have to complete, I know we can get bogged down in some of these screenings, especially things like I quickly reviewed the Columbia Suicide Severity Rating Scale and can understand it. I'm a nurse practitioner, did primary care, so really assessing patients' mental health. I understand the importance of the scales, but there's a job that we're trying to do, and getting bogged down in that type of scales, it just seems like we've expanded government yet again and the requirements for you all. One thing that I didn't, so there's, I think, a discussion we had about, do we really need all of those scales? Because you know pretty quick if you're dealing with somebody who's in trouble and who's not. And one of the things that is not listed on these scales that I'm interested in, just from talking to veterans in my district and understanding depression and suicide, is are we ensuring, and I guess this is a question maybe for Dr. Scavella or Dr. Burnett, but ensuring that we're looking at their med lists and what these guys are taking, because I know that you talked about talk therapy and all the other components of and the scales and everything else, but there's so much that chemical imbalance. And I have seen firsthand, time and time again, when we administer medication to these patients, and most of them carry black box warnings about the increased risk of suicidality. And I have seen it like night and day, like flipping a switch. And I usually would have my patients come back a week or two after we start a new medication. Are you feeling better? Are you feeling worse? Do we need to change course? Are we looking at that too? Is that one of the assessments that we're doing? Because I don't feel like we've talked about that a lot.
Yeah, so thank you for that question. One of the things we do at every visit is medication reconciliation. So we're looking at the medications they're on. We're also questioning whether or not they need to remain on something they may have been on for a while. Mm-hmm. Can we reduce the strength? Can we reduce the frequency? Can we discontinue it altogether? So those are questions that our clinicians are asking at every visit. Looking at potential side effects from medications that they're currently taking, yes, that is something that is included. And we don't just have our clinicians who are involved, but we have a group of clinical pharmacists who are also part of the care team, who are also doing that look to assist our clinicians with those assessments and those reviews.
And is that being done in some of our other care organizations, that the rest of you guys just not leaving out that medication component? I've heard even from special forces guys that say, we got a bag of medications. Their spouses would say, we found this bag of drugs. We don't know what it is. We don't know what it does, but this was given to them by their team doctor or by their, so just making sure we're having those frank conversations about what medications you're ingesting. Do you know what they're for? Do you know what they're called? What side effects they carry. So are we looking at that from the other side too?
That is not something that we're currently assessing. We do not employ any clinical staff.
So as a clinician, that is something that I look at, and our staff are trained to look at as well, because it is instrumental in determining risk factors associated with veteran suicide. So,
How about you, Mr. Falke?
We do look at medications as part of the intake summary, and it's been amazing to me. We had a colonel in one of our programs, a retired colonel, who's on 34 different medications. So it's been super disappointing to me. But I think, I know how it goes. I'm a patient at the VA as well, so I know how it goes. And you just get one drug after another, and you start to store them up and take them. So, but we do look at it very closely.
So in my perfect world, I shorten this assessment list that you guys are required, and I put in a medication assessment by a clinical provider who can understand those interactions and some of those side effects profiles. So thank you for that. Let's see, also for Dr. Scavella and Dr. Burnett, for just continuity of care, I feel like is a really important piece that I feel like when we have our initial assessments it's a team effort by some of our other care organizations, is the VA doing a good job with that continuity of care piece? Because that's where we lose people, and we get them either inpatient or, these initial assessments, we get them, but then we lose them. So can you talk to me a little bit about what that looks like?
Yeah, so care coordination is really important. We reach out both internally and externally when our veterans may receive care outside of our actual system, to make sure that we have all the information, that we can do the proper follow-up, and also if it's vice versa, they're leaving us to go somewhere else to do the same thing. Is there anything you would like to add, Dr. Burnett?
And do your other care organizations provide continuity of care pieces as long as needed?
One of the things that we've really talked to the VA about is how do we get most of the people that come to us don't go to the VA. So what we want to do is make sure that they get over there, and that's really what I believe that we make our participants better patients. And that's one of the things that happens is you lose agency and you start to believe things, and that's why you take drugs that maybe you don't need. So to put a patient who's been through our program into the VA with better agency and better to be a better patient, I think it really creates a win-win for this program, because it's going both ways.
Very much so. It can't be overstated, and I'm out of time, but thank you very much for all that you do.
Thank you, Representative Kiggins. The chair now recognizes Representative Wadawagon for 5 minutes.
Thank you, Chairwoman Miller Meeks and Ranking Member Brownlee, for holding this hearing today, and thank you to all of the witnesses for your testimony. Dr. Scavella, how does the VA address organizations that are unable to meet established metrics of success within the Fox Grant program? And are there accountability measures in place, such as removal or reduction of funding?
I'll start, and I'll pass on to Dr. Burnett eventually, but we're still early in our process, so we do a lot of engagement and the support of the organizations who have applied to be part of our program, who are grantees. So if we see something that's not going quite as expected, as planned, we want to support those organizations to try to get them into compliance, but we do have a regular follow-up with them. Dr. Burnett?
Yeah, I'd echo that. Most of these grantee sites are yet to complete a first full year of running their services, and so we're still evaluating those outcomes. Of course, we do operational oversight and business operation oversight to make sure that they're spending those funds appropriately, that they're using those funds for eligible veterans and partnerships that are within the scope of the legislation. As we get that information back, we'll be happy to share that with you in the interim report that we'll provide in the spring.
Thank you. So, Dr. Scavella, how much flexibility do grantees have in using their funds? And if for whatever reason the original grantee found themselves at risk of failing to execute the grant, could an otherwise qualified third party be designated to receive the grant so that funding remains within the target community?
That's a great question. I'm actually going to look to my expert, Dr. Burnett, for this one.
Yes. So if a grantee, if I understood your question correctly, if the grantee is underperforming or is unable to execute appropriate funding, can that funding be reallocated to another? There's a couple answers there. A grantee site, of course, we want to promote innovation. And if they ask to change the scope of their grant to provide different services, they always have the ability to request a change in the scope of their services, which we will support them with. If they're unable to provide those services or something happens at their facility, we will then pivot those funds to others to cover the veterans in that area.
All right. Well, that's it, Madam Chairwoman. I yield back the balance of my time. Thank you.
Well, thank you very much. I now yield myself 5 minutes. The advantage of being the chair is that you have to stay during the entire hearing, and so you get to listen to the questions and the answers by all of the members of Congress. So I'm going to toss out what I thought were the questions that I was going to ask, and I'm going to try to hit on some of the points made by our members. First and foremost, let me just say that I know that my colleagues, all of them here on the Health Subcommittee and on the Veterans Affairs Committee, are extraordinarily interested in this topic and want to see the number of veterans suicide and the brain health of veterans improve. They want to see the numbers decrease. They want to see brain health increase. And I know that that too is the VA's priority and their mission. So I'm going to first say thank you for all of those efforts. However, we know that the number of veteran suicide remains high. It has not dropped. And in the spirit of innovation, I think what we're trying to say to you is it shouldn't be members of Congress coming up and touring in their districts or elsewhere, innovative programs, coming back, talking to the VA, and or passing legislation to force the VA to do something that if this is your priority, please, I ask you to go outside of the box and find those programs and those entities that are doing that work in concert with you, whether or not they are being given a grant by the VA. Incorporate those, bring those to us. Let us know that you really are thinking about how to best address this issue. One of the things that we've heard today is the 9 different assessments. So as a physician and a veteran, I understand what the VA is trying to do. The VA is trying to standardize the entry process so that you have the data and metrics that members have asked you for so that we can assess the effectiveness of the program. And you're trying to apply the same standards done within the VA institution to these outlying organizations. I get it, I understand it, I don't fault you for that, but those assessments aren't working. What we hear from our veterans in our district is I go to the VA, even if I'm trying to make an appointment on the phone, I'm asked all these questions. They don't have anything to do with what I'm doing. So perhaps I would say one of the things, Dr. Scavella and Dr. Burnett, you can take from this hearing is tailor that, narrow it, find out what it is that you need to do in order to have metrics and data for effectiveness, but tailor it for our communities. Number 2, the cost of medication. We're not figuring in the cost of all these programs. So Dr. Scavella, how much is the VA spending per year on mental health and suicide prevention? All dollars.
So I'd have to get that information to you.
Okay, please get that information to us. So in this, if you have an individual who goes to Missy Meyer's program, or goes to Ken Falke's program, or Joyce King gets someone to a program, or English River Outfitters in my district, or Heroes with Horses in Wyoming. If they go to one of those programs and they're on 4 or 5 medications and they're taken off, what's the cost of those medications? Because that's also in the cost of success if an individual is off medications. And I don't disagree with what Representative Kiggins or Representative Luttrell said or Ken Falke said. As a physician, I can tell you, and having worked with this and worked in the VA, someone comes in, they're prescribed a medication, they have a side effect or something else. Part of the medication's working, but something else has happened, they're prescribed another medication. We're not treating people holistically. So I get having, and I'm just gonna make a comment from one of my colleagues. The reason you have the assessments that you do is that we need to know that we're treating people the same severity, the same support groups, the same attempts at care, whether they're within the VA or outside of the VA, because saying that X number of people went into this program and only X number of people committed suicide doesn't really tell you the data. It's anecdotal, and what you're trying to do is get real data. So you're attempting to apply structure and standardization to this program to validate and determine effectiveness. But we need to do better. So that's what we're saying. We need to do better. We need to lower the rates of suicide, and we haven't seen that through the VA. I'm going to also say that I actually support these programs. I've toured these programs. I've seen whether they're faith-based, non-faith-based. We know that there is an individual, a holistic patient, and this includes the suicide risk and TBI, which should be included. This is a program that I think that we're all willing to support and see continue. It's really just in its infancy, even though it's 3 years. But we'd like to see the VA take greater steps, get more grants out there, simplify the assessment and the data so that we can determine effectiveness. And with that, I thank you and I yield back. Does Ranking Member Brownlee, would you like to make any closing remarks? Seeing no other representatives here to ask questions.
Thank you, Madam Chair. I just want to say that this is an important hearing. The topic is obviously important and complex. This is not an easy issue. I think that this particular grant program has great opportunities to be wildly successful. It could be wildly a failure as well if we're not doing the proper oversight. And I feel as though the VA's role in terms of working with these grantees across the country is really to intervene with all of these grantees in a positive way, to kind of check in to see how are you doing, where are your metrics, what's driving your practices here. Maybe we need to adjust to get to where we're trying to get to. And I just think that we have to approach this in a business model, if you will, that's very much a data-driven, continuous improvement model, that every single grantee, that we are funding is really focused in that way and knows that they have to be data-driven, they have to be continually improving their program, and I don't know whether the VA even has that capability to be overseeing all of these grantees across the country. I know you're there to provide a service for grantees who need and want your assistance and help, but I'm not sure that you're closely following each and every one of these grantees. And that's what I think, if we do something like that, I think we can be wildly successful in this. And I don't think the VA is going to solve this problem by itself, that we need the help of experts across the country to help us in this endeavor, to help to solve this problem. But we've got to be able to do it. We can't do it and I'm not saying that we're doing it in a willy-nilly way, but we've really got to approach it in a very serious business model and for it to succeed. And I think the grantees are grantees that we can look to that have been successful and can help others. But we've got to really approach this, I think, in a very data-driven way. And I worry that we're not going to be collecting all of the data points that we should be collecting. So with that, I yield.
Thank you, Ranking Member Brownlee. And I realize that in my question, I didn't have a lot of questions that I asked, but I think that you understand the suggestions that I'm making. And in addition to the data that Representative Brownlee and others suggested, acquiring about medications, about sex, we also should be, and when you provide us the information, looking at active duty, National Guard, and Reserve broken down, i.e. members that are leaving active duty military and transitioning have a different transition out of the service than members of the National Guard or the Reserve who are deployed for a set period of time and then go back to a community, so how they integrate back into their community. I'd like to thank everyone for their participation in today's hearing and for the productive conversation, and I appreciate everyone's focus on such, it really is a critically important topic, and also all of your dedication to decreasing the number of veteran suicide. It's important to me and my colleagues on both sides of the aisle that all veterans seeking help receive it in a timely manner. It's our responsibility, this committee, the VA, and our communities, to lift veterans at risk out of isolation, get them out of trouble, treat them as whole people within a family and a community, not just a VA hospital community, and we get them the care that can save their lives. If you are a veteran watching this right now who needs help, please know that help is available to you anytime by calling 988 and pressing 1, or texting 838-255, or visiting veteranscrisisline.net. I'd also like to just say, if I can, I have to pull this up on my phone, so I apologize for the delay. You've already heard this from Ranking Member Brownlee, and as a closing note, I want to take a moment to recognize our outstanding staff director, Christine Hill, who will be retiring at the end of this year, and over 30 years of federal service. I haven't worked with her as long as Ranking Member Brownlee has, but in the 3 years I've been on the Veterans Committee and the Health Subcommittee, she has just been outstanding for her time here, from her time in the Air Force to her work here as a staff director of the Health Subcommittee. Christine's life has been about service. I'm grateful to have been able to work closely with her on the Health Subcommittee this year, and while she'll be sorely missed, we wish her the very best in retirement and know that she'll continue to serve. Thank you so much, Christine. So the complete record of statements, today's witnesses, will be entered into the hearing record. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks to include extraneous material. Hearing no objections, so ordered. I thank the members and the witnesses for their attendance and participation today. This hearing is now adjourned.